questions. You are also welcome to provide feedback about this session so we can improve the quality of the events we are developing on your behalf. You are also encouraged to provide suggestions and recommendations for topics to be included in our upcoming sessions. It is now my honor and a great pleasure to introduce our eminent guest speaker, Professor Stephen Duffull. Professor Stephen Duffull is a professor of clinical pharmacy and pharmacometrics and a former dean of School of Pharmacy at University of Otago. He was registered as a pharmacist in 1986 and practiced in hospital and community pharmacy and worked and trained in the Department of Clinical Pharmacology at Christchurch Hospital for 10 years. During this time, he completed his master and PhD degrees. His PhD involved with the design and the analysis of clinical pharmacokinetic studies. Prof. Duffull took up a postdoctoral position at the University of Manchester, working with Dr. Leon Aron in the area of pharmacometrics. He was then appointed as a lecturer at the University of Queensland, Department of Pharmacy. And in 2006, he was then offered a position as a professor of clinical pharmacy at the University of Otago, where he has worked since. His expertise in pharmacometrics involves the quantitative design, analysis, and the inference from the pharmacological studies. In particular, this involves optimal design and population analysis techniques for pharmacokinetics and pharmacodynamic data. His research involves the development of pharmacological models, modeling of data, and the design of clinical studies. His research projects essentially revolve around the therapeutic areas of coagulation, malaria management, and clinical toxicology. He has a part of his research with an interest in therapeutic decision making. So, thank you, Professor. Thank you very much, Professor Duffull, for accepting our invitation and to be with us today. With that, I turn it over to you. Prof. Duffull, the floor is yours. Thank you.
Thank you very much. I'll share my screen. Right. So thank you very much for the opportunity to talk today. It's a great pleasure. I'm not sure there's much science in my talk, but we will talk a little bit about games and education. So please let me know if there's any issues with our connectivity at any stage. So we're going to chat about serious games today, in particular with respect to teaching and pharmacy curricula. This is a aerial view of Otago University. This is the central campus part, which is a part I don't work on. I work about 3 kilometres towards this way, towards me, and it's not like this. It's not as nice. But anyway, this is the main building over here where the Vice Chancellor of the University lives, and this little stream that flows through, which floods once a year. So decision making, there's obviously a big team behind this, and these are some of the people, not all of the people involved in this. So people like Dan Wright, Kyle Wilby, Megan Anakin, Ainsley Peterson, all involved in the decision making team. We've got a virtual patient team, and we've got a SimPharm team over here as well. And my thanks go to all those people for helping working our way through this project. So in this particular talk, we're going to have talk a little bit about some background stuff on decision making, simulation gains for learning, and SimPharm. I'm getting quite a bit of feedback actually. Is there? Yeah, thank you. SimPharm and education, and about virtual patients. So therapeutic decision making. So this, I guess, in some sense, the concept of therapeutic decision making, as it's currently described, goes back maybe about 2 decades. And Dan Wright wrote an article in 2018, and he described it as a cognitive process and skills, etc. So the cognitive process means the fact that it happens up here in your brain, but the important element of this means that you can't see it. So you can't see a student thinking and what they're thinking. That's the first element which makes it complicated. It's a skill, which means it's teachable, it's learnable, and it's transferable. There's a key point here. So which means that if we can teach the skill, then the students can use that skill for this and other elements like that. That allows pharmacists or health professionals to make patient-centered decisions about therapeutics. That's important. And this is where it differs from other types of decision-making processes. So there are mainly 2 types of clinical decisions that are made in clinical practice. One is a diagnostic decision, which has typically have been the realm of medical practice and some other areas, and that one's therapeutics. This concept was reviewed by Cook and Jammer in 2018, but essentially the diagnostic process is a single choice and it's not negotiated. And diagnostic and therapeutic decision making are not interchangeable in terms of the skill set that is involved. So the idea of diagnosis is to assign a label to a patient, and that label then allows someone to understand how they will be best managed. And it's not negotiated with the patient. So the patient doesn't have to agree with that label. So if you assign a label to a patient and say you've got this condition, the patient doesn't have the opportunity to say, well, I don't want to have that condition, I'd rather have this condition. So it's very different that way. In therapeutics, we of course have many choices, and that may be the ultimate goal is we may have 5 or 6 different things we could use, and these are negotiated with the patient. So these 2 types of decision makings are both skill-based processes. This is in the area of clinical reasoning, as most publications. This has received much less attention in the last couple of decades, but these are not transferable. You can't learn from this and apply it to that. You have to teach them separately. So when we think about therapeutic decision making, our team breaks this down into 4 basic components, which is information gathering, clinical reasoning, clinical judgment, the decision. We can see information gathering and we can see the decision process itself. The decision is the enactment of the decision. And both of these, for instance, will be with the patient. These are externalized, and when our students do them, we've got some way of both moderating and evaluating how they've done. However, the clinical reasoning and judgment part, this is tacit. So clinical reasoning is in some sense defining what my priority is and what options I have, and judgment is thinking about what's the risk benefit of any of those particular options. And that's tacit. It's hidden, it's up here, it happens in the brain. I can't see it. I don't know how my students are doing it, and we have no way of knowing, are they doing this in an effective way? And in some sense, the work we've been doing in Otago over the last 4 years has been trying to unpick this element and learn more about how students think about this and then try and optimize their process. So to do this, we've used simulation and games. So we're going to have a little bit of a brief overview of simulations and games, just to go over that and make sure we're clear on those points. So this is really my view on the process. There's not that much published on the simulation game interface, like when is a game, when is a simulation, etc. So I'm going to make some postulates in the beginning to help us work forward. So I'm going to postulate that all games are simulations, but only some simulations are games. So now we're going to define what a simulation is and what a game is. Then we're going to determine how do we use these items to help our students learn in healthcare. So a simulation is an imitation of a system or a process. So in an imitation, it's usually simplified, it's decluttered. So the idea is that what we want to do is we're going to take the principal construct and we're going to declutter, get rid of all things which are not relevant, which are relevant to the process, and then the student can go and do that particular activity in a simulation platform, so a simulated platform. So for instance, the resuscitation dummy, when students are learning about CPR, doesn't have any arms or legs. And that's for many reasons, by the way. Arms and legs in this case are irrelevant to the resuscitation process. And the other point is that when you're storing the resuscitation dummies, if they have arms and legs, they take up more space. So it makes sense. So there's two elements. There's a practical element, but also the element is that the student is not being, if you wish, distracted by things that are not relevant. And it's a simulation because it's an imitation. So simulations may be both on a computer, they might be some real life thing, they might be like a dummy, etc. The realism of the simulation is sufficient for the student to demonstrate process, which means in this case, if we think about our resuscitation dummy, the dummy has to have a torso. The torso has to be able to move and associate with pressure, and it has to then be able to show the diaphragm moving. The simulation is a single virtual realization of system response. So what I mean by this is that when you have a simulation, each simulate itself is an example of what might happen in real life. So it's a single realization of the whole system. And the simulations often confused in the literature. Simulation and games often confuse each other. Games are sometimes confused with gamification. There's all different things. So we're going to unpick these a little bit. So the 4 reasons we use simulation for learning are 1, to perform a tacit task. So a tacit means hidden. We want the students to practice doing something that cannot be seen or judged by an instructor. So if they have to do something like a manipulation or some element like that, our physical examination or making a decision, if I can't see it, then they need to do it in a way which then allows me, so I have a simulation platform which allows me to assess what the students are doing. So resuscitation dummies, of course, is our example, which we've been using. When you depress on over the sternum a certain distance, the item clicks, and you can tell how far the student's depressing with each compression to determine both the position and also the appropriateness of that action. We use simulation for doing something rare. So if we want to do something which we don't normally see, it's important, but we don't see it in clinical practice every day. So the student doesn't get to practice it because they just don't see it enough. For example, treating rare diseases. So you may see a particular condition coming in, say, once every 2 months or so. The student won't get an opportunity to work with that. And of course, using our resuscitation example, that's another example because we don't resuscitate people on a daily basis, weekly basis, monthly basis. Most practitioners who don't work in an emergency framework probably resuscitate someone maybe once or twice in their whole lifetime, but they still have to practice. When you're doing something risky, so if you're practice doing something that is high stakes, so if you want to do something which has got significant ramifications from getting it wrong, then you want your student to be able to do this in a way which is, I guess, safe for the student, it's safe for the practitioner, and it's also safe for the patient, obviously. And the other reason we do simulation, we can upscale. The idea is we need to be able to upscale this to many students simultaneously. Obviously, if we're working students going out to placements, working with patients, that's can be upscaled, but it's difficult and complicated because it's a complicated arena. Whereas if it's a simulation, you can upscale a simulation from 1 student to many students with relative ease. So that's a simulation done. Now we're thinking about a game. Now remember that a game is a special type of simulation. So a game itself is a set of strategies that are developed by a player to reach a goal. And obviously we can use games like chess as our thinking about that. So chess has some skills about moving pieces around. Then the person develops a strategy about what they're trying to achieve. And then they may have a set of strategies which they try and then use those for then winning a game of chess. So the concept of a serious game is just a game that's used for training. So I think if you use the word serious game to people who play chess and say chess is not a serious game, I think this would probably not go down well because I think people think about chess as being a serious game because they take it seriously. So the word serious here is not being used in the same context. It's just a training game. So if you can exchange the word player with learner and then change artificial setting with realistic setting, then that's how you change a game into a serious game. So a serious game, the player is actually a learner, and the artificial setting becomes a realistic setting. So in that circumstance, a serious game is simply an extension of a normal game, but we've now changed the platform, so the platform now has some resonating, interesting properties. So lots of types of games. Here's some examples. There are in situ games. So these are games that occur in real world environments. A lot of people are using things like escape rooms when they're training people. So, and this is an escape room occurs where students, for instance, or people are in an actual room and they've got to try and solve a puzzle to escape from the room. And this occurs in a real room, in a real environment. That's what we call an in situ game. There are non-serious games, which are games which are used for fun only, not for training. There's gamification. The gamification is what we do here is we change a normal real world activity, but we then apply a reward to it. So if you did this, you'll get a reward. If you do this many items in a certain period of time, then you get a bonus, if you wish. And then the idea is then how can I optimize my efficiency of my process so I get as many rewards as possible. And this is how we change a normal real world activity into a game. And we call this gamification, which is the process of changing real world into games. It's not quite the same as developing a game from scratch. So what do games have in common? So irrespective of how they're developed, games have certain things in common. So the important thing is they lead to development of authentic game-based behaviors. And this is the goal or the outcome of playing a game. And it's unintended sometimes, but it is what happens. So the term authentic means that a player develops a behavior that's implicit to the person, so it belongs to them and aligns with the game. So we'll think about some examples. We can use, for instance, a PlayStation driving game, where essentially, usually children, but adults as well, sit down in front of a PlayStation computer and they drive their car around the place. Then a gamer will usually get better over time as they develop behaviors based on rewards, which means the fact that they win races because they're driving better. So in the process of doing this, that player develops skills to play that game and they become better at playing that game. But in this case here, these skills are not transferable to the real world. And therefore, this makes this a non-serious game. If, however, we then have a game where the game is sufficiently realistic that the knowledge, skills, and behaviors associated with the game are transferable, and the game develops authentic behaviors in the person, then this will be now a serious game. And of course, the question is sufficient. How close does your game need to be to reality for the skills that develop to be able to be mapped across to real life skills? And of course, this is with the complexity attached to building games, as to how realistic things need to be. So there are 5 essential elements in games. The first element is interactivity. So this is the difference between a simulation and a game, if you wish, to some extent. So if you're resuscitating the dummy, if you remember our resuscitation dummy, resuscitating it never gets better and lives. So you can't change the course of the life of the resuscitation dummy by resuscitating it. But in a game, the user can change the course of the simulation. So when the participant plays the game, the course simulation can change and therefore the outcomes can change. Games require a strategy to solve the problem, which means they're naturally problem-solving skills. And this strategy, of course, we can use in therapeutic decision-making. They're fun, so people enjoy playing the games because they're different, they're fun, they're engaging because they require people to solve problems, and the problem is presented in a way which makes sense. If you have engagement, then you can develop immersion. So if a student feels, for instance, they feel concerned about their patient because the patient's not doing very well, and that level of concern is caused because the student is immersed in the game. When they become immersed, they develop authentic behaviors. And those authentic behaviors now in a serious game can be then mapped across to real life authentic behaviors. And the game naturally self-orientates to the learner's level. And by that we mean the fact that the game can be easy or hard, and therefore the learner can, for instance, over time, get better at playing the game with different levels. So if the game is fun and credible, then it can develop engagement and immersion, which then develops an emotive response and then authentic behaviors. And those authentic behaviors are a skill which is learned, and it can be transferable to other settings. So some desirable game characteristics. Scalable, which means that you can have 1 or 100 students playing the same game at the same time. Sustainable, which means you can continue to do so in your curricula. It requires minimal tutor requirements. So you don't want a game which is going to tie up all of your instructor staff such that they can't do other things in their life. So it needs to run, in some sense, therefore, the game needs to be autonomous. It needs to run autonomously and self-controlling. It needs to be student-focused, which means that the game is centered around the student and the student's behavior, rather than the student has to change to be like the game. Obviously, it needs to be fun. Most games are fun. And it needs to be education delivery agnostic. By that we mean it doesn't matter if the student is face-to-face with you, is how you normally teach, or you teach at a distance, or you have a hybrid model, or COVID comes along and causes all your students to go at home and self-isolate. So it needs to be agnostic to your delivery approach to education. So we started developing games in Otago. The first one I was involved in was 2007, and it was called SimFarm. It's a problem-based learning game, and it was a paper-based case and consisted of 65 pages of notes. So the game went over about a week, and then as the students did things, then we would then identify what set of notes that were relevant to that, and then we would send those set of notes to the student. And this is all kept in this ring binder here. And then as the students moved through the case, they could then unfold or unlock different elements of what was happening with the patient, then allowing them to grow their picture of the patient and also their treatment strategy. Students interacted with the case via a facilitator or a tutor, and they were evaluated on their process. But this was massively resource prohibitive. So essentially one tutor looked after about 4 students. So, it's fine if you have a small number of students, but if you had 100 students, there's like 20, 25 tutors taken up in this process, which is way, way too much. So it was useful, it was a good exercise, and it worked well for very small classrooms, but it wasn't scalable, so it wasn't useful for us in the full time. So in 2009, we developed an autonomous real-time computer simulation application, which we then tested, and then that version was then trialed in 2018, so it had some years of development in the process. And now in 2022, we've had some 4,000 student case experiences with over 200,000 student case hours used on this particular product, SimFarm. And it's all run now in a virtual environment. So what is SimFarm? So SimFarm is an application that generates, assigns, monitors, and controls virtual patient behaviors. So essentially, when a tutor instructs a case to be available to the student, the SimFarm generates the case, it assigns the case, it then monitors the student progress, and then controls the behavior of the virtual patient. Virtual patients are based in the cloud, and they're autonomous. Autonomous means the fact that they're self-autonomy, which means that the computer system SimFarm controls the case entirely, and at no stage does an instructor have to interact with the student or the case. And these cases can be accessed by the students from any locations. They can access it from anywhere where they have an internet connection. So it could be at home, could be in the park, could be at university. So the virtual patients. So a virtual patient is a simulative of a real patient. So it's a single example of a real patient. And the student can interact with these virtual patients in real time. So real time means 1 minute of real time equals 1 minute of virtual time. So if a student interacts with their patient and then goes and takes a break and has a cup of coffee and comes back again 10 minutes later, then 10 minutes of the student's time in real world has passed by, but also 10 minutes of the patient's time has moved by as well. So in this regard, the students often run cases sometimes as short as 1 hour, but sometimes as long as 48 hours or 4 days or 5 days. The cases run autonomously, they don't require a tutor to be present, and the cases respond authentically to interventions in real time. So by that I mean if a student does something, then the real-time element of that, so the drug, if the student gives the patient a drug, the drug that's orally administered has to get in the stomach, has to disintegrate, has to dissolute, dissolve, then be absorbed into the bloodstream, and then get to excited activity, have some activity that takes time, and it happens in real time. So virtual patients in SimFarm can be constructed to cover acute, chronic presentations in both primary and secondary care settings. There are a bunch of different pathologies and other things in there. So when students play the game, they have something like 500 plus medicines they can choose from. So how do students interact with their virtual patient? So they can do so from any internet capable device. So typically we recommend a laptop, but it could be a computer station, could be the phone, could be a tablet, as long as it's internet capable. the SimFarm system doesn't run on their app on their hardware. It runs on the computer cloud, which means they can turn their computer on and off and it doesn't change the course of the simulation. So students are assigned an instance of a virtual patient. So instance means that I might assign one patient to 100 different students, and then those 100 different students will get 100 different instances of that case. And the responses that the virtual patient have may vary between instances, which means each student might get a slightly different experience interacting with their patient. Students can interact with their virtual patient to learn about the patient, to review notes, to ask the patient or medical team questions, check for symptoms, signs, order lab tests. They can enact decisions, which could be to initiate, modify, or discontinue medications. So the SimFarm is set up for therapeutic decision making, and therefore the choices they have to do in terms of decisions are about starting, stopping, adding new drugs, etc. And cases can last anywhere from one hour to 7 days. They can last shorter or longer periods of time, but that's typically the time we develop cases over. So for a 1 hour case, the student might sit with the case for the whole 1 hour. For a 7-day case, the student would normally interact with the patient for, say, 20 minutes twice a day for the first couple of days, and then 20 minutes a day for the remaining 4 or 5 days. So it's not particularly onerous for the student. And SimFarm keeps a log of the student's interactions so you can see what the student's done. SimFarm does not provide any didactic feedback to the student, but rather the student gets to see what happens. So by didactic feedback, so if a student prescribes a drug, the system doesn't say that's not according to guidelines or that is according to guidelines or provide any response at all about that. But the student does get to see the consequences of their actions. So if a student prescribed an antihypertensive and a patient who had hypertension, then the virtual patient's blood pressure would reduce, and that the student would be able to see that, and then in so doing work out, was their dosing strategy appropriate. So here's an example where students, when they first play SimFarm, they like to test the boundaries of the system, so they'll give their virtual patient an overdose of a drug and see what happens. So in this particular case here, here's a time record. So at 8:15 in the morning, a student prescribed morphine 50 milligrams intramuscular to a patient who is naive. And then at 8:17, 2 minutes later, there's some mild respiratory symptoms. And then another minute later, the symptoms are worsening. And then at 5 minutes later, the patient is unconscious at this page. And all orally administered drugs have been disabled. So this is the time course of action. So at no stage did the system stop the student say 50 milligrams of morphine is a potentially lethal dose. You don't want to give this. It just lets it happen. And then whatever unfolds, unfolds. Small overdoses take longer to work because it takes a while for the concentration to get high enough to cause respiratory depression. So what's the purpose of SimFarm then? So we use it for engaging with our students with clinical presentations of diseases and the effects of drugs, to reflect about evidence-based medicine versus clinical pharmacology. So evidence-based medicine, this is the idea of applying a guideline to my patient. The other idea is individualizing dosing of drugs to meet my patient's needs. So the guideline might work for the average patient, but for some patients might over or under treat, and therefore it allows students to see, okay, I still need to individualize drug care, even though I'm giving the recommended guideline treatment. And of course, it's all about problem solving, which means in the problem solving is centered around therapeutic decisions. So it implicitly includes therapeutic decision making as part of the process, and students learn by reflection. So, and we evaluate the students' decision making and reflective processes when we have debrief sessions. So this is sort of the background, a little bit about simulation and games, and then a little bit about, I guess, therapeutic decision making, trying to understand how we think about it in Otago, and then of course the SimFarm product, which is what we use to generate virtual patients and games. So now I'm going to talk a little bit about how we've embedded this into our curricula, with the purpose of trying to get some sense about what we think about decision making in this regard. So TDM here means therapeutic decision making, not therapeutic drug monitoring. So the dash here is my way of reminding myself this is therapeutic decision making. So in year 2 of our program, so ours is a 4-year program, undergraduate program, and then we have another postgraduate year after this. So that we have an introduction to therapeutic decision making and an introduction to SimPharm. Then in year 3 and 4 we have various different topics in therapeutic decision making which are taught separately, and then we have those reinforced by them interacting with virtual patients in SimPharm. And then in year 5 we have advanced topics, more complicated cases. So topics in therapeutic drug monitoring, sorry, I've said it myself actually, in therapeutic decision making, I apologise. We have 3 basic types of topics. We have things like reducing complexity. So this deals with the student's ability to take complicated patients, identify the key issues, scope out practice requirements for those issues, and then identify what options are available for those issues. So it's about making complicated patients down to a simple series of things which I can then do. Topic 2 type things are about building decisions. So I've got to make a decision, but there's ambiguity or greyness in the area I'm working in because there's a risk benefit and not all decisions are going to be simple in patient life. Then of course there are communication, such as dealing with notes, writing notes, handover from one group to another group, care of multiple cases simultaneously, these sorts of intercommunication components. So a little bit about virtual patients from the Otago experience. So when we use a virtual patient in teaching, we use it to give the students an opportunity to reflect. Therefore, we have to teach the students about how to reflect on these things. So we have a game-based logic which allows each student can change the outcome of their virtual patient. So as we learned before, if I give my patient overdose of morphine, then this may cause my patient to become unconscious and then be removed from my care. And this therefore develops a learning opportunity for the student to understand why did that happen and what was the consequences of that. So it's a reflective based process, reminding us of student does not provide any didactic feedback based on guidelines. So we think about our reflective cycle. So when we think about reflection, we think about this cycle here. Normally in our world that the reflection has normally been the provenance or been the area of work-based learning. So students go out onto placements and spend time on placements, and at those placements they then do activities, they see the outcomes from those activities, and that allows them to learn in a reflective way. And that's certainly true, and it's one of the reasons for work-based learning. But we can also do this in a controlled virtual patient environment. And the student does something, and if they do something like an activity, they have an intervention, they prescribe a drug, they then see that effect of the drug. And then the critical part of reflection is then they own that. So they then, the idea is the student, they do something, they see the outcome, they then know they did that. Therefore, they own that process. When they own the process, then they have the capacity to break that process down, to examine what were the parts of that, how did it go together, what was my activity which caused that to occur. I can rethink this now. Could I have done better? And then I can do the cycle again. So the key at the moment, ownership. The student has to have autonomy for the reflective cycle to have its full component. So you need to have a situation which a student can do something without somebody looking over their shoulder to get the full reflective element. Otherwise, it's always going to be reflective conditioned upon someone stopping me from doing something bad. So a typical education scenario with SimPharm. So students are assigned a case, usually a week before class. They interact with that case in a self-directed manner, which means they choose when to log in or not. Students are encouraged to discuss their case with their peers. So we often have students discussing treating a particular patient, and it could be in a lift in the building, in a common room, etc., because they're engaged with it. But the other thing is every instance of a patient is different. So if student 1 tells student 2 about the case doesn't necessarily mean that they're talking about the same thing, because different things may have happened. Students attend a debrief session afterwards, and they have an opportunity to rerun the case afterwards. So when we're debriefing our students, we've got this sort of contingency table of decisions and outcomes. So we've got good decisions and bad decisions, and we've got good outcomes and bad outcomes. So if the student makes a good decision and the patient has a good outcome, so let's think about that. So They say that the virtual patient has got pain. The student administers some analgesic and the pain is relieved and the patient feels better. Then this is a good quality decision and it's got a good outcome. And the student can sense this. They can reflect that process they used worked. Let's take another situation where it's a bad decision quality and it had a bad patient outcome. So we can use our example of our morphine example previously, where a student gave an overdose of morphine and then the patient stopped breathing. And then this is a bad decision quality, but it had a bad outcome and the student can see that. Therefore, it's an opportunity for self-reflection. I gave too big a dose, I need to give a small dose next time. If you have a bad outcome, a bad decision process and a good outcome, or a good outcome and a bad decision process, a good decision process and a bad outcome, if you have that, this could be, for instance, a good decision but the patient had a side effect, or a bad decision process. So I gave the person the wrong drug, but the person had a good outcome anyway, which is common in real life. These both require guided reflection. This means with the use of a facilitator. Otherwise, the natural reflective process of the student may go wrong and set the student on a wrong track for future learning. So just some brief recent examples to wrap up. So we did a thematic-based analysis of some students' experiences with virtual patients. So this was just to get some idea as to how they enjoyed it. This is back in 2018. So we had 120 second year and 115 fourth year pharmacy students consent to take part in the study. All students used SimPharm for practicing decision processes. And we developed 4 themes which came through. So the students identified that putting themselves in the driver's seat was critical. They felt like they owned this process and they were able to do something without somebody else standing over the top of them. They felt like they were making meaning of what they were doing and they felt like they were behaving like a pharmacist. They realized or felt the implications of committing to a decision, which means it's not just a matter of saying in class, I would use that drug. When they had to do it, the commitment to that decision was much stronger in their feeling and made them much more concerned about their decisions, and they enjoyed it. So playing serious games was fun, which is good. That's what we wanted. So here's some example quotes. It gives you control. You've got more skin in the game because you were the person making the decision. It only happened because you did it. It made it more real as the person was more than just name on paper, etc. And things like, what if I prescribed the wrong medicine? All of a sudden, these things now were more evident because they were doing things rather than they were just talking about it in a classroom system. And the anxiety after missing, interesting. So the game caused students to develop some sort of emotive response to the scenario, and that type of anxiety then, if you wish, embeds behavior processing and authentic behaviors. So another study we did, this was published in the Journal of Pharmacy, was sort of learning about therapeutic decision making, but we used SimPharm as our tool in the process of this. So we're sort of measuring it. It's hard to measure therapeutic decision making. We don't really have a good way of doing it at this stage. So in this case, we had 28 students. These were postgraduate qualified pharmacists who are in for postgraduate training. 17 were from community and 9 from hospital. Students evaluated on the decision approach to clinical vignettes before and after taking our therapeutic decision module, which included virtual patients. Vignettes A and B were randomized. The students got A first or B first in either a pre or post period, and it was approved by ethics. Did the students' skills improve? This is the vignette score in terms of their decision-making process. And we see now there's a pre-intervention and post-intervention that we had a better outcome in terms of their vignette approach, which is their score on their decision-making process for the vignette. The other corollary question could be asking the question, well, was vignette A more difficult than vignette B and stuff like that, and did that affect it? So when we looked at the vignette A versus B, we found no difference in terms of their complexity, in terms of how the students considered that process, which suggested that the decision process we use, which means the decision module, which includes SimPharm, etc., seemed to be beneficial. We looked at some distance IP education. So interprofessional education is a critically important part of modern curricula. And I've looked at 2 studies here, one looking at scalable pharmacy and medicine. This one here looked at pharmacy and nursing. So the interprofessional education is, and I put interprofessional distance education, so I put a D in there because I think we should be able to do this at distance as well, because with COVID we often have students who are isolating but still need to do things with other health professionals. So on the scale here, you've got foundation to advanced years, you're increasing complexity. So initially, students from different disciplines and professions have some pre-exposure. They often work in workshops or have chats about things and have discussions with each other to learn a bit about each other. And then we may have a full immersion process where we have student-led wards. So students on a ward situation in a real hospital looking after patients with obviously supervisors supervising it, but the students are interacting together as a team. And that's obviously a fantastic opportunity, but very, very difficult to scale. And what we need to have is more space for engagement. Engagement so students can learn from, about, and with each other. That's what we think we can do a little bit with SimFarm. So in pilot one, we only had 3. These are pilot studies. We had 3 fourth-year medical and pharmacy students paired into teams. They had previous training in SimFarm. They were synchronous into an initial socialization, which means they met each other first before they started doing this. Then they were assigned a 2-day multiplayer case, which they did in separate locations. Then they had a synchronous debrief. Under pilot 2, this was in the time of COVID, we had 5 final year nursing and pharmacy students had previous training in SimFarm asynchronous initial socialization, which means they socialized only on a Zoom type framework. We assigned them a 2-day multiplayer case, and then we had an asynchronous debrief. Asynchronous means the debriefs were at different locations and different times. So in terms of the MedPharm, the thematic analysis, engagement, and immersion, so it got quite attached to the patient. I think it'll be useful. Asynchronicity, and our SimFarm log files revealed most interactions were asynchronous, which means that what happens is that the medical pharm student may log on and leave a note for the other player, the other team member, who then read that note and they did something. And that's what often happens in real life. It's not usual that pharmacy and medicine travel around at the same time always. They often just leave notes for each other. And they had many meaningful interactions. They had 5 to 7 shared decision makings according to log files. For nursing and pharmacy, I was happy with the improvement we got. We decided things together, we could bounce ideas back and forth, come to decisions, so they were definitely learning from with each other. There was asynchronicity. Analysis of the SimFarm log files reveals again that most interactions were asynchronous, which means that nursing or pharmacy students were logging onto the SimFarm game at different times and leaving notes for each other in the system. And they had meaningful interactions with 4 typically shared decisions, and things like sorry, I've just lost my. There we then so made more sense of my partner explained. So this is the idea of learning from each other. They learn with each other and obviously a little bit about each other, and they learned about the pressures of planning forward, which is a critical concept, which means they need to plan for what's going to happen in the future and have a plan for that before it happens in case they're not both there at the same time. So just some final thoughts to wrap up. So the how of decision making remains an important topic in pharmacy education. So how do we best teach decision making? And there's lots of ways of trying to evaluate tacit tasks. You might have things like speak aloud. This is where the student walks through their decision process by speaking what they're thinking aloud, and the tutor can hear that. And it's quite an effective method. Of course, the difficulty with that is when you say things aloud and you hear yourself say it, it can change the decision process as you're making the decision because you can hear yourself say it. So the does of decision making can be expanded to virtual patient games. So I think the idea we've been looking at is that students can now practice decision making using virtual patients autonomously rather than only do this with real life patients in clinical settings. And incorporating the owns of decision making into the virtual patient environment provides a unique opportunity for effective learning. So by this, I mean, the student has to have access to their system autonomously. So when students do things by themselves and they know they did that, they can own that outcome for good or bad. They may think, oh, that was a terrible outcome. I want to hide it from the tutor or the instructor, which is fine. But there's a learning experience in all of those elements. And that's the finish of my talk. And I want to thank everybody for their time. I'm going to stop sharing my screen at this point, but obviously happy to take questions.
Yes, thanks so much, Prof. Steve, for this very informative presentation. You have enlightened us about the games and how to use them in education, in pharmacy education, and developing the competency of clinical decision making or therapeutic decision making of students. Um, Now we are starting our question Q&A session. We do have a question here. How could SimPharm be applied for students' assessment during clinical pharmacy exam?
Yeah, so what we've done in the circumstances, we have applied SimPharm ahead of time, so the students interact with a case ahead of time, and then we, in our debrief, we have that as an oral exam. So, reminding ourselves when students are playing a SimPharm game of a virtual patient, that even if they all assign the same patient, each patient interacts differently, and therefore they can't, if you wish, copy each other, or I did this, therefore I should do that. So then when we have an assessment, we would normally do this in an oral exam format, so like a viva.
Okay, great. So the assessment here depends on the interaction between the tutor and the students and making sure he understood the concept of the case or understood the clinical decision process and dealt with the patient. Yeah, and so the action and that stuff.
Yes, good. Yes, exactly. So it would be set up typically, but not always, along the lines of the student identifying what their priority was, which they were going to treat, and therefore this is them working out what of all the things that were happening with the patient, what they decided to choose to work on, and then to describe their decision process. And then the viva bit is so that you can then ask questions if the student can elucidate further about some decision processes, like, for instance, the information gathering components, like what lab tests they may have done and why they did them, what options they were thinking about, why they chose that particular dose of the drug, how it turned out, like what their outcome, what were they monitoring, and so forth. So just go through that and walk through it with the student, and the student would then describe that. The tutor would have the case in front of them so they can then assess the student against both of those things.
Yeah, that's really great. And I saw you were talking about the reflective practice and the debriefing sessions, providing constructive feedback after the interaction with the patients. I believe this is most of the learning process happens in this part of the simulation. So great, thanks so much, Prof. Dr. Iman, she has a question, and she's thanking you for the great presentation. Her question is about the computational perspective. How would you evaluate the SimPharm performance from computational perspective? Meaning that does the model give the appropriate feedback?
Yeah, so I guess the question partly is the model authentic or credible? Would be the case. And there is, I guess, when you're doing a simulation, there's always an element of what we call suspended disbelief. So suspended disbelief is a construct which says that I know this is a simulation, but it appears to be authentic enough for me to develop immersive behaviors. So I'm going to give you, and this is a really good question, and it's also a little complicated. So I'm going to give you an example, and then we can think about what that means. So you've probably all seen the Sim Man. So Sim Man is a physical dummy which you can actually give drugs to, inject drugs and resuscitate, and it does react and behave accordingly. And it's controlled by a person in another room. So when the students interact with it, they can then the dummy can talk and do all sorts of stuff. So it's a very clever bit of apparatus and bit of kit. Students, though, having said that, know that it's a dummy. And they often say the fact that they know this is a dummy. They do some things. They go through textbook processes, but they don't necessarily become immersed with it. So things which are high audio, visual, tactile, sort of high fidelity, don't necessarily cause immersion. Immersion causes because of the brain. So, so even though that the students, it looks like a real person, it's not a real person. They know it's not a real person. It doesn't feel like a real person. It just looks a little bit like a real person. So this is about the authenticity component. So the moment SimPharm's engine, which is based on a systems pharmacology mathematical model, emulates reality sufficiently that the students become immersed in the process. But it doesn't do everything. Don't be wrong. You can't do everything, but it's got it's got something like when you're running a patient, it may be calling us something like 500 or 600 differential equations to solve something for the particular person, but it just needs to be sufficiently realistic.
Yes, yes, that's great. I saw while you were talking, Prof. Steve, you said that the system does not provide deductive feedback.
Mm.
Wouldn't it be possible to, if the didactic feedback is available for students in addition to the discussion and the debriefing and the reflective practice they have after the simulation, would it be an added value, or you don't think it will add a lot?
Yeah. No, that's another really hard question and really good question. So SimPharm does give the student a summary of what happened in the case at the end of the case, but it doesn't give didactic. So didactic feedback, here's a hypothetical. So hypothetically, let's say your patient has got secondary Raynaud's disease and hypertension, and you choose a beta blocker as your first treatment choice. Now, the beta blocker is going to aggravate the Raynaud's, which means the patient get blanching of their fingers and really cold fingers, but it'll be useful for their hypertension. Now, the problem is, think about how many different combinations of conditions exist.
Yeah.
Now, didactic feedback is fine if you're going to say the normal dose of morphine in somebody naive who's giving it intramuscular is 5 to 10 milligrams of morphine as an injectable intramuscular dose, and you gave 50 milligrams, which is a bigger dose. But on that case, so you could, in theory, imagine giving didactic feedback in some circumstances, but it'd be really hard to give didactic feedback in all because cases are complex.
Yeah.
And because of that, we don't always know what the right answer is going to be. We know the wrong answer sometimes, but we don't often know the right answer, if that makes sense.
Yeah, it makes real sense. Actually, the interaction with the case and seeing the actions after taking the decisions, in my opinion, is more productive in terms of developing therapeutic decision making for students more than even the didactic. In addition to the complexity you mentioned, Prof. Steve. Prof. Abdullah Dirbala, he thanking you very much for taking time to this seminar, saying it's a pleasure to talk to you again. I have a quick question. Does the SimPharm platform allows for time scale to be accelerated beyond real time so that students can see the long-term impact of their decisions?
Yeah, it's great. Thank you very much for the question, and it's great to chat. That's yes and no. So because it's a real-time simulation, that the pressures occur in real time. So by pressures in real time means the fact that if you got something acute to do, like pain relief, then you'll feel a pressure attached to that. If you're doing something long-term like blood pressure control, then you'd then not have those pressures, but then you realize also you've got more time on your hands. So can you fast forward? Is the question we're asking. And the answer is there is a fast forward feature in SimPharm, but cases don't go longer than 1 week. We don't use the fast forward feature because it's still numerically too challenging for us to allow the fast forward feature to be used. I'm not convinced education is a good idea because for 1 week case, students can log in and out over the period of the week and just not do it so fast. It doesn't have to be intensive. We need to allow students to have the right white space, which means blank space from using the case to be able to internalize what they're doing. But of course, your question is not about that. Your question is about, if I'm treating someone with alendronate and their bone mineral density is changing, will I see a change in fracture in 3 years' time? And the answer is no, SimPharm can't do that.
Yeah, I saw while you were presenting a case that extended beyond 1 week, I think. Is this for chronic diseases or so?
Yeah, no, we don't. Well, at this stage, we're not running cases for longer than 1 week. But I think historically cases could have been set to run for longer than 1 week, but we're not running cases for longer than 1 week because the system is basically for an acute, post-acute setting. So it's a lot like the idea of somebody coming into hospital for 3 days, 4 days, not the sort of idea of 3 months being readmitted with to hospital with heart failure, or 2 years being admitted to hospital with a broken hip, sort of thing. It's not that sort of thing. It doesn't simulate that. That's not the right platform.
Yeah, sure. Another relevant question from Dr. Iman asking about how do you take into consideration other factors in virtual patients case management, like in chronic diseases? How do you deal with chronic diseases? How do you give students the sense of chronic diseases and how to manage them?
Yeah, that's a good question. Depends on the condition, really. So this takes some conditions like, say, diabetes, for instance, as a chronic, manifest chronic disease. So for that particular one, we've got both short-term and long-term biomarkers of interest, which allows us to modify our treatment plans. So that's able to be done. I think in a purely long-term, such as bone mineral density setting, then I think that's more complicated because, if you add something like a bisphosphonate at that point in time, and you've got, literally years to wait before something's going to happen. And so what we need to do then, and this is the same in real life, by the way. So how do we know we've given the right dose of a vaccine to someone? And the answer is you don't. So, when you're teaching our students, what you do is you teach students, you give the dose of the vaccine, which has been defined by the product label. In other words, you follow guidelines exactly, because that's how you know it's working. So when your feedback does not allow you within a cycle to work through and then adjust your decision process in a cycle, then you have to follow guidelines, because that's all there is.
Yeah.
So if you've got a biomarker which is transient and quick, you can use that. We use that a lot. If there's no biomarker, then you just have to follow guidelines, and then you can debrief according to guidelines.
Yeah, I see the beauty of the learning process happening in this cycle while the patients are seeing the actions again and owning their actions, being responsible for their decisions. And this is really amazing. Thank you, Prof. Dr. Iman, in continuation for her question, she is curious about the underlying model. Is it a rule-based model or a machine learning model? Is it reinforcement learning?
Yeah, that's a good question. Okay, so thank you for that. So the original design for SimFarm was rule-based because it was run by people. So if this happened, is an if-then construct. But now it's not rule-based. So it runs on I guess a series of ordinary differential equations, to put it just like that. So it's not machine learning. It doesn't learn this. The student hopefully learns from the system. The system does not learn from the student. Okay. So the system has no process in it which they can internalize what the student's done, but it does have targets. So it's basically, it has a series of mathematical models which change biomarkers. Some biomarkers you can monitor, some you can't. Those biomarkers are then linked to symptoms and control symptom pathologies and constellation of symptoms. So then when the biomarker changes, the symptoms change, and then this allows you to be able to see that. And that's essentially how it works. So it's not rule-based, and it's not machine learning in that sense, in the sense that the machine itself doesn't update itself. How's that?
Okay. Yeah, thank you, Prof. Dr. Bara is thanking you for this important, informative presentation. Dr. Helwan is thanking you for the great talk, simple and to the point. We have a question from Dr. Shahira. Are there several levels of complexity with regard to the virtual patient, and is everything evaluated by similar? So if the information gathering or the communication step is faulty, will the student and tutor see that?
Okay, so there's a couple of bits here. So virtual patients may have different levels of complexity. So my students yesterday were running a case of a patient in an ambulatory care setting who developed a severe asthma episode while they were in their community pharmacy, and then it was about their management plan for that case. And that's the only thing the patient had. There was no complexity attached to that. It was a severe event, so it was quite, I guess, quite compelling for the student. versus a highly complicated case with polypharmacy and all sorts of stuff happening and all those things interacting with each other. So both those levels of cases exist. But the question you're asking now is, so if there's some error, I don't think I actually understand. So saying by some of the information gathering or the communication step is faulty, you mean if the student's communication step is faulty or what SimPharm is telling them is faulty? I'm not sure I understand. So if the students, if the student has a faulty decision process, which I'm going to take this as being what you're talking about, I'm just paraphrasing, I apologize if I've got it wrong. If the student has a faulty decision process, then that will be picked up in a debrief. So the purpose of the debrief is to pick up those times when the student's natural reflective process will set them on the wrong path. So a bad decision, a good outcome is the worst outcome for us. Because if they do something which is wrong, but the patient still gets better. And then we have to unpick that with the student and work through that process. That would be like a faulty reasoning or information gathering process.
Yes, this is really interesting. I was wondering while you present, when you talked about the different outcomes in connection to the decisions, and in some of them we saw a bad decision that is giving a good outcome. And here we have guided reflection. What do you mean here by guided reflection, and how can you distinguish it with the self-reflection? What's the difference between both of them? And how do you see the good outcome with the bad decision and its impact on the learning process for the students?
That's the bad decision, good outcome is the worst case. So yes. We'll do that. The good decision, bad outcome is this would be example. Somebody gave like a penicillin to someone and the person had an anaphylactic reaction. And what happens in this circumstances is that the student makes connections between these events and it starts to imprint on them. And what we need to do now is to reduce that imprinting, because next time they use penicillin, they'll be looking out for anaphylaxis. This is an imprinting process. So as part of our facilitation, we'll work with them to help them understand. And one way, simple way of doing it, if we chose a penicillin example, if you had 100 students in your debrief, which you wouldn't normally do, but if you did have that, and you ask, put up your hand if your patient had anaphylaxis, and only one person puts their hand up, because it's an extremely rare event that happened completely by chance, then they'll be able to say, oh, okay, so 99 other people had a very different experience from me. And this helps them then to normalize their experience. Because when you're running it, same as in real life, when you're treating a patient, that patient's experiences becomes your experiences, because you internalize that and that builds your imprinting process. So if you use something, so what we want to do is make sure that when something happens, we have an ability to normalize that effect. The other process where a student does something wrong and so does a bad decision process, but has a good outcome. So let's think of a scenario here. So here we go. So if a patient has got congestive heart failure, they're on furosemide, they're on an ACE inhibitor, and they've developed a sprained ankle, and the person starts them off on a 1-month course of a non-steroidal. Now, only 7% of people who you prescribe this in will develop what we call the triple whammy. And the triple whammy is where the person goes into acute renal failure. Yeah. So the chances of your patient going to acute renal failure on SimPharm is only 7%, only 7 times over 100. So 93 times the student will say, oh, pain got better, everything else went fine, it's all good, I'm going to do that again. And then that's essentially now what we need to do is we use something called good judgment as our process, where we then unpick the student's decision process using a good judgment approach to debriefing, which then hopefully allows the student to be aware that this was a probability statement rather than a guarantee, but that this could have happened and this is a risk attached to that. So, yes. So that's what this is about. It's about understanding that component, and that requires that we may need to talk to the student afterwards if they're unable to reflect in a debrief setting.
Yes, sure. And here comes the importance of the debriefing and reflective practice to unlearn and relearn is the right decisions and the importance of this process. So another question from Dr. Mahmoud Ibrahim asking about the continuous changes of the guidelines. Is that reflected in parallel in the developed software?
Yeah, that's good. Yes, I like that. Thank you.
And
Because this is one of the reasons why we don't give didactic feedback. Imagine if I gave that the drug of choice for treating hypertension was an ACE inhibitor, but then magically in 3 months' time it now became an AT2 blocker, and it became, you know, valsartan or something, whatever it's going to be, it doesn't matter, losartan. Then we'd have to change that, but it doesn't give any feedback. That's the beauty, is that whatever, so in your debrief, you might ask, well, I'm interested you chose that second line drug in your debrief. Can you explain why you choose that second line drug rather than the first line drug? And then what you now is after reaffirming their process, they can describe that to you. So guidelines are not a problem. They can change as much as they want to. What we do have to do, though, the corollary is if a new drug comes out, I have to add it to SimPharm if we think we're going to be using it. So SimPharm is not a complete, it only has like 600 drugs in it. So it's not a complete repository of all drugs. It's just, there's too many drugs available.
yeah,
But
and
does that, yeah.
sorry for that.
I was
Please.
going to ask if that answered the question.
And I believe it's the responsibility of the student to choose the right drug or right decision based on the changed guidelines or based on the updated guidelines. And then again, during reflection and providing constructive feedback, we should discuss these points, I believe. Yeah.
So actually, I'd add one more thing to that, actually, because it's an important point, is that we usually use SimPharm as a tool after the student has learned about the system. So we might have had some lectures and workshops looking at, say, I don't know, hypertension, and then the student might run a SimPharm case on hypertension. So it's used as a consolidation of their process. We for undergraduate students, we don't use SimPharm as a way of the students learning about something from scratch. They can do it, but they need much more help. Postgraduate, yes. But undergraduate, we don't tend to put in a completely new condition I've never heard of before, because the cognitive load about learning something new in real time is quite high. Because when they learn about hypertension and stuff like that, you know, well, and they learn about anaphylaxis, it might take them, say, a couple of lectures in a workshop to do anaphylaxis, and then a skills workshop. That's like 3 days. So in anaphylaxis, you're treating anaphylaxis, you've got minutes. So you've got to think about the duration of time. So we often have a lot of teaching up front, and then SimPharm comes in as a consolidation. So they consolidate the learning, and it includes multiple pathologies of everything they've learned over the time. So SimPharm cases, say in the middle of semester 3, will then include all of the things they've done in semester 3 and semester 1 and semester 2. So therefore it's always cumulative learning. It doesn't have everything, but they can have any condition they've learned to date in that semester.
Yeah, I saw you were presenting about starting early to use SimPharm since second year, I believe, or it was just learning students the process of clinical decision or therapeutic decision making, or when is the actually the best place to integrate it in the curriculum if you are going to adopt it?
No idea. So I don't think what we do is perfect here. So our first year is a health science first year. So it's based in science, and they do lots of pharmacology and stuff like that. In their first semester of their second year, they do a pharmacy type paper, and then they do pharmaceutical sciences. And then in their second semester, second year, they start their clinical type of papers. And about one half the way through that, we then have our first we have a teaching session on decision making, and then we have a session where they run a case in class and apply decision making principles to treat an acute scenario, and that's when they get to play and have some fun. And then they do that in class. And then third year, they then run SimPharm autonomously, which means out of class. They do it in their own time, and they come back later. Yeah, so I think you need to start it whenever they start learning about systems and patients. It's about the time you need to start embedding the process of decision making. We are imperfect in Otago with respect.
That's great. I believe the early exposure to such types of simulation prepares the students for the future internships and then practice and stuff. So it's a great strategy you are using in Otago. We have a question from Professor Sam Sroor about there are different environmental and cultural factors in disease complexity. Does virtual patients consider this as part of the complexity? Do you consider all these factors?
Yeah, well, okay, so partially and partially not. So you don't have an opportunity to interact with SimFarm in a culturally, I guess, aware fashion, because it is just a computer. So there's an element that you can't bring that element to play into it. Can you have SimFarm written in different languages? Yes. But language is only part of culture. The other thing is, can someone's background change their response in clinical pharmacology? And yes, you can do that. So in SimFarm, if you choose, so you can't just select somebody from a particular region of the world and then have the SimFarm make a case about that. But you can, for instance, make someone particularly sensitive to a drug if you want them to be, or less sensitive to another drug. You can change the individual patient's sensitivity to things, which could emulate people from different locations in terms of their, genetic polymorphisms, etc., can vary across the world. So essentially only from a clinical pharmacology perspective. That's as far as it goes. You don't get the stage of having a culturally relevant interaction with your SimFarm patient.
Yeah, I believe I interacted with SimFarm before, and I think there are some parts of social history and family history things are available in some cases. So I believe this can serve as a purpose partially, but
Partially, yes.
partially, yeah. But it would be great if we can make a kind of or availability of customization for socio-cultural context in different locations of the world. If you want to be
Sure.
to be
Yep.
adopted globally.
I think that's a great idea. In fact, I've been working with a group of people, the indigenous population in New Zealand, Māori. I've been working with Māori providers to develop a version of SimFarm which would work in Māori framework. But what we've got to do first up is determine what exists in the current product, which can be repurposed a little bit, versus what new things we may need to develop in order for this to be more, I guess, culturally aware of what's going on. But end of the day, it's not a communication tool. So you'll always have to teach communication with your patients separately if they're using SimFarm.
Yeah, sure. Because this part is not that easy to be taught using such games or simulations.
Mm.
I want to here remind my colleagues that if they want to unmute and talk to you, they can just raise their hands and then we can allow them to have direct interaction with you, Prof. Steve. Another question here is about if SimFarm is free of charge
No.
to be
No,
used.
it's not. No, it's licensed and developed by a group called Education Management Solutions. So you'd have to contact them, and I don't know how that works. So I don't know. I don't know anything about how the marketing works for SimFarm, but it has to be paid for.
Yeah, but I believe they give a kind of free trials for people who are interested. I think so.
Sure. Yes.
Yeah, yeah. Thank you so much for your nice presentation from Dr. Mohamed Gaballa. Could we use for market application? Could we use it for market application, or it is designed just for educational purposes?
So I guess the question, I'm going to paraphrase that question and say, could you use this as a tool for treating patients? The answer is no.
Mm-hmm. Okay.
Remind yourselves, this is a simulation tool. Yep. So that would be my, and in fact, there's a disclaimer on the product saying the fact that this is not a, so you wouldn't, for instance, go and got a patient in a ward, go and create that patient in SimFarm, treat the patient in SimFarm several times, see what worked, and go and do it on your ward patient. You wouldn't do that. I don't know if I've interpreted that question correctly, but please get back to me if not.
Okay. Dr. Hosni Ahmed Hosni is thanking you very much for the great talk. Dr. Ayman Waneem is thanking you for the nice talk and asking if SimFarm depends on domain knowledge. How symptoms are related to their causes, illnesses, type, and how treatments affected treating these symptoms. Is this domain knowledge available, and in what shape or in what format?
So this depending on domain knowledge. I'm not quite sure I understand the question. Just trying to see if I can figure out what you mean by this. So
I have feeling from my readings for the question that he might be asking about the knowledge part, and in my opinion, I think. Knowledge is inherently learned here inside the the simulation game, because students here should have some kind of knowledge about the drugs first, and then when they interact with the simulated patient or the virtual patient, they see the action of the drugs, and this adds to their knowledge in addition to seeing and recording the actions in an interactive way. So I believe knowledge is in the background, um, according to my understanding. If you want to elaborate, Prof. Steve.
No, I mean, you're right. I mean, obviously, that I think to play the game SimPharm, you'd have to have the domain knowledge of being pharmacy or medicine or nursing, etc. The types of symptoms that arise in appropriateness with the therapeutic area you happen to be having a patient written in, whether it's cardiovascular, respiratory, diabetic, etc. Then symptoms arise as appropriate for those therapeutic domains, and I think therefore that you would just, if you as a tutor or instructor, you would create a case which had the domain areas which you've taught to support the students' learning. Like, for instance, if you haven't taught them about rheumatoid arthritis, then you could just easily not put that in the case, but you could put things you had taught. I think that's maybe part of it. Yeah, but I think you'd have to be a healthcare professional. I don't think you'd be able to run this case without any knowledge of anything like this at all.
Yes. I heard you, Prof, during the presentation talking about problem-based learning and giving the case for the patient 1 week ahead before starting or things like this. And I'm wondering which type of curriculum would suit this type of games the best? Is it discipline-based, integrated curriculum? And which types of teaching strategies would suit it best? Is it problem-based learning, or team-based learning, or other traditional? Is it okay with other traditional ways of lecturing and then making applications, or what?
Okay, it's good. It's a really good point, actually, and this is really about style of education. So, SimPharm is agnostic with respect to the delivery type, whether it's a face-to-face distance. It makes no difference. It works both ways. It's not quite so agnostic, I think, with respect to the style of the pedagogical framework. So, if you had a very didactic style program, which some universities have that, where essentially you lectured to the students and then had tutorials where you taught them more details about that. So in other words, it was very much a tutor-driven educational platform. I think SimPharm wouldn't integrate as well in that, because this requires the student to interact and do things by themselves and to workshop things in problem-based learning. But if you've got a curriculum which is oriented towards students solving problems, if that's the style, then I think this naturally segues in. Both those are completely reasonable approaches to teaching. It's not about that. Just that this fits in much more closely with a style where we want to challenge your students. We want to ask them, so here's a scenario, come back and tell me what you do in an hour's time. So if that's the sort of style of teaching, all teaching, by the way, is probably hybrid. We still have lectures where we, tell people about stuff. But the question is, in the non-lecture times, do you have an opportunity to have those problem-based approaches where it's not necessarily PBL, which is a very specific style of learning. We're just going to call this an interactive style, which allows students to be challenged and to challenge the system, and then to ask questions, and then to learn about how to do things because they've learned about it, because they've looked it up, because they've thought about it.
Yeah,
Does that make
really
sense?
nice. Yeah, please.
No, that's it. Thank you.
Yeah, it's really nice to fill, like you said, to fill the non-lecture time with active learning strategies, like interacting with these simulations and games. In addition to the fun it provides for students, and making the educational process a kind of fun, not like a cognitive load or just burden of study. So thank you, Prof. Professor Sameh Surur is asking about um, if you can elaborate a little bit about the data you have used to build such a system, the data collection process.
Yeah, no, okay, it's good. Okay, right. So the system was built from let's take an example. So the system, say, a respiratory system was built. The module within it was built on known principles of the physiology of the respiratory system. And so how it works is that the known mechanisms that exist are written in code, and then we simulate from those and then calibrate the response so that it meets this response that you'd see. So here's an example. So let's take cardiovascular one as our example. So if you think about something simple like cardiac output as a function of stroke volume and heart rate. So if the heart rate increases to above a certain level, the time for filling decreases and the stroke volume decreases, the cardiac output actually goes down even though heart rate is high. So it's a very, very, very simple example of a scenario. So the whole system was built on physiology of the situations with then pharmacological targets added in. And then those pharmacological targets were then meted against literature values. So basically you look up, ACE inhibitor effect on blood pressure, and then you review that literature, and then that gives you an idea as the response time and so forth. And that is calibrated in the system. Does that make sense?
Yeah. It makes a lot of sense. It's a tedious process, not that easy. Dr. Ayman Ghunaim is saying that the first version was rule-based, and he said the rules are the domain knowledge. Are these rules available for sharing?
Yeah, well, it's sort of not. Yes, I see what you're saying. It was the first system. The first one was paper-based case, and it was rule-based because the students got a piece of paper with like a page of writing. They read through that. They worked through what they thought was going to happen. If they asked another question, they'd say, ask a question. Then the rule simply would be, if the student does that, then we do that. That's the rule-based, and that's how the rule-based system works. It wasn't like a fuzzy logic type rule-base in that sense, or another type of rule-base. It was more just a sense that the instructors were using a rule-based system to interpret the student's response to something. So then they could then provide information accordingly. So rule-based just means everything was then transformed into a logic yes, no. Yeah. But the actual game itself is not rule-based.
Yeah, I have another question. I think we are done with all questions here, but again, I remind my students, if you want to interact with Prof. Steve directly, you can just raise your hand, unmute yourself, and talk to Prof. Steve. I have another question, Prof. Steve. I'm wondering, in some cases, the response to the action you have taken can take a little bit of time to build up, to see the action. I mean, you take the decision and you need some time to see the action. And we saw a case of morphine injection, and after 5 minutes, the patient became unconscious within 5 minutes. In some cases, it's not that. In the real life, it is not that quick. So how can you adjust the relation between the time and the period that it takes in the real life to build up or to see the action, and the short time to see the action within the virtual simulator, within the game?
Okay, so let's take a example perhaps. So the example might be that if you think about insulin use, you're going to be thinking about their fasting blood glucose and glucose over the period of a day. Okay, that's a quick acting, short term, and then you might think about the HbA1c. So there will be a longer version. So if you've got a case for 7 days, then you're not going to see a change in HbA1c, but you will see a change in their fasting blood glucose. So at the end of the day, that's as far as you can get. Now there is a perhaps another version of SimFarm coming out where you can generate appointments and then fast forward the patient by 1 month. And then you'll be able to see those longer term effects coming through, such as, for instance, HbA1c. But yes, at the moment it's not. So it's not fast forwarding through time in the time you're seeing the patient, just when your appointment. So there is an appointment basis in SimFarm, which has not been finalised yet, where if at the end of, say, you meet your patient for 1 hour, and then after 1 hour, then you can fast forward to the next appointment, which might be, say, 6 weeks' time. And then in 6 weeks, you get to see the patient again. But instead of waiting 6 weeks, you can just see the patient in like the next hour, whenever you decide to press that fast forward button.
And it's clear in the game that this increase in the blood glucose level will happen within hours, and hemoglobin A1c will happen within months or
yes,
weeks.
Yes, it's already, yes, it's already in there.
Okay,
Yep. So
that will set their expectations to the real life.
Yep, the slow and fast processes are already in there, and they already cope. But at the moment, we don't have the ability to fast forward between appointments. I know it sounds good, but there's a technical element to it which we've got to resolve, and I'm not sure if this can happen today or tomorrow.
Okay, yeah, that's great. I believe a last question here from Dr. Abdullah Dirbala is about how many ODEs. I'm not sure what ODEs stands for.
So it's a good. So ordinary differential equations. So that's what Abdullah's asking about. So in the physiome itself, there's about 80 or 90 ordinary differential equations, but it dynamically creates them as it goes. So I'm going to give you an example. You have 2 ordinary differential equations for every drug that you add. So if you add 14 drugs, for instance, if there are 14 drugs, there'll be 14 more. And then every time there is another condition arising, that will then generate another 1 or 2 differential equations. So it depends on how the case arises. So for instance, if your patient develops something over time, the system may dynamically create more differential equations to solve for that.
Yeah.
So in theory, there could be several hundred differential equations, or there could be simply 80 or 90.
Yeah, thanks, Steve. So if I can follow up on this question, so how many in the system itself are coded within the system?
Well, the code of the system, there's probably overall about 300 plus drug ones, but they're not available or active until the student does something, and then they become available.
Yeah.
So it dynamically change them. So the system is capable of, in theory, of handling somewhere like 400 differential equations.
Thank you, Steve.
Thanks, Dr. Abdullah. If we have any other questions, please just raise your hand or add them in the chat. I think we answered all questions in the chat function. Yes, indeed, and in competency-based education world, and because pharma is thinking beyond the bill, then pharmacy will have to think beyond the fill. And we as educators, we have to respond to and cope with these changes, and believe gamification in pharmacy education is a nice way to improve the engagement of students, to make their learning process a kind of fun. Thanks so much, Prof. Steve, for the inspiring talk today, and for we learned a lot actually today about gamification and how to improve pharmacy education and to make our graduates future ready. Thanks so much for this presentation. With that, many thanks for everyone for the attendance and attention and interactivity. With that, I give the floor to our respectful Dean, Professor Samah Sroor. Prof. Samah, over to you.
Thank you very much, Mohammed. Thank you, Steve. I think it was really very, very interesting talk. It is very important, actually, if we are talking about currently in Egypt, at least we are talking about the improvement of pharmacy education and how to take care more of the skills you give to your students and the interprofessional learning and experiential learning rules. And I think using such tools in the future will not be an option. I think it is really important. If we are talking about training, how are you going to prepare your students to get benefit the most of the training when they are in the hospitals or in the community pharmacy working? They will need to have a prior step. And I think such games will attract the attention, as you have shown in the studies you have done to assess this system, to prepare the students for such type of learning. And I think this will be part of the future education of pharmacy. I thank you really very much. And I would like to invite you once more to join our Let's Talk Science next time for research in your discipline, the pharmacometrics. I think we will be very delighted to have you once more. I would like to thank Dr. Mohamed Baraka for the excellent moderation and the very good question he raised and formulated to you. I thank all the participants. Actually, I enjoyed the discussion. I think the discussion took much longer than we expected, and this reflects how important and how engaged were our participants. And I would like to thank the team working on organizing Let's Talk Science from Faculty of Pharmacy, Helwan University. The end, I would like to invite you for the next session. April will be in Ramadan, so we are not going to have a session in Ramadan. It will be difficult. But in May, we will have Dr. Aaron Leyer, Associate Professor of Pharmaceutical Science from Wayne State University. And we will be happy to have you all once more in May. And thank you, Steve, once more. Thank you, Dr. Mohammed. And hopefully you will have both of you in the future. Thank you.
Thank you. Thank you very much. My
Bye-bye.
pleasure.
Thank you very much. Salam.